Well, hello everyone. My name's Chris Burton. I'm Professor at Canterbury Christ Church University, and I'm Chair of the Council of Deans of Health Research Strategy Policy Group. A very warm welcome to this webinar as part of the Council of Deans Research Month. I would like to introduce Professor Kath Sackley. Kath is Professor of Physiotherapy Research at the University of Birmingham, a really experienced rehabilitation researcher with a long track record of research funded by the National Institute for Health Research and other prestigious funders. Kath, many thanks for your time today. Really looking forward to hearing your presentation.
Thanks very much, Chris. Really delighted to be able to talk about my research. So I applied for a National Institute of Health Research Global Health Group grant in 2017, awarded 2018. And this was to carry out a study looking at stroke in Sierra Leone. There are a lot of people involved in the partnership. You can see a list of some of the people involved here who were co-investigators on the grant or worked with us. But actually, this is a tip of the iceberg. There were a lot more people involved, most of them based at King's College London or the King's Sierra Leone Partnership, which is I was going to say NGO, but it's part of King's College London, but was established during the Ebola crisis. So the NIHR fund research that is going to make a clinical difference, or potentially within 5 years. So we're looking at that end of the translational pipeline. So this were 5 clear work packages, 1 management, 2 capacity building, 3 community engagement, which is the term global health used for PPI, 4 stroke register, and 5 a small nurse-led pilot intervention. It was 2 million, initially over 4 years, but then we had COVID, and now we've got some underspend that we're going to use for dissemination. So next slide, please. So work package 1 can't be underestimated. We made a mistake here not to set this up well enough, because the money for global health comes from UK aid money. So although the NIHR manage it, the demands and governance, demands for information, financial information are much, much higher than a normal large NIHR grant. So lots of meetings, most of these shared with the NIHR, minutes shared with the NIHR, with an external oversight. The financial management was incredibly complicated. So very complex, dealing with the governance issues. For instance, currency exchange rate fluctuations, which in a low-income country can be huge, enormous changes, and multiple agencies within that low-income country. There was a really heavy requirement for reporting, and at one time I felt this was detrimental to the time we had. And the financial reporting was extremely difficult, with audits down to cost of a pencil. But low-income countries, it's very difficult. You do not automatically get receipts, travel costs aren't receipted, things like that. So that was very time consuming. Next, please. So work package 2 was about capacity building, and we didn't really use an established model, and I think looking back that might be something to do next time. King supported us with some match funding for PhD and MSc fees, so that was really supportive. So we had a number of people register for higher degrees. The PhDs could not complete in the time, but they've gone on to win external funding, which is great. And we've got 2 masters, 2 stopped at diploma, which you were able to do. So usual formal courses, good clinical practice, consent training, that kind of thing. A lot of experiential learning, a lot of NIC staff employed, and some UK volunteers. There had to be clinical skills training, as stroke care was very underdeveloped. So this was concentrated on the junior and some senior medics, so CT scan interpretation, that kind of thing. And then we developed some training packages for nurses and physios to do with basic stroke care. COVID inevitably brought a delay and change in how we manage those. Okay, next slide, please. So work package 3 was the community engagement, and then we did some qualitative work from this. The idea of consumer engagement or feedback is alien in a lot of low-income countries. So establishing this was difficult, but key to the delivery of the project, but also any sustainability. And we had a wonderful research assistant, Jessica O'Hara, who had Sierra Leone some heritage, and so was able to speak Creole, which made a big difference. So we developed a stroke survivor and family group, which went on to get formal NGO status. The World Stroke Organization helped us support them through there. They've linked with other sub-Saharan African groups. The interview study was looking at people's experience of stroke, including informal caregivers and health providers. And that was embedded within the cohort study. And that's the protocols published in the main paper is going to be published. There are some key differences around experiences within a health system, within a low-income country that does not have a universal health system of any sort. Next slide, please. The stroke register was the main research package, and that was based on the South London stroke register methods. We were very successful in recruiting, even during COVID. So nearly 1,000 participants recruited across 2 hospitals. Good follow-up, high follow-up rate, which is worth pointing out. A lot of this is done by phone. The 1-year results are published, and we've just had acceptance of the follow-up data study as well. Thank you. Next slide. So we wanted to use the results to do a small pilot study. And we found that a huge number of people were dying with pneumonia, thought to be aspiration pneumonia. But managing and screening for that presents particular challenges in a low-income country. So we carried out a review and then tried to introduce a screening system, and we ran that on a 35-patient pilot study. So that was run completely through us being online because it was during COVID, but we did manage it. Next slide. So we're now delighted to work with colleagues from Canterbury Christ Church University, Queen Margaret University and the NIHR on process evaluation. So we're looking at the implementation of CISL. So I think one of our big wins is to get stroke on a national strategic plan for the first time. And that's a major output for the study. And now we're planning the dissemination. So thank you.
Kath, thank you very much. I really enjoyed listening to that presentation. I've got some questions for us to have a conversation about, but before I do, I just wanted to pick up on a couple of things that cropped up during the presentation, just perhaps to get a little bit more information about. You mentioned the capacity building work package, and I guess many of the members of the Council of Deans will be working with international partners to design educational training programs. Just tell me a little bit more about how you went about thinking about the design of that work package and what seemed to work, some of the challenges that you had.
Yeah, I have to confess to not knowing about the literature around this before I started. So it was very much a sort of trial and error process. I think I would do it differently and probably do it better now. But we tried to encourage people to register for online MSCs. The mistake we made was not putting in a support package for that.
Around people transitioning into the MSc or okay.
Well, the whole thing, because people had BScs, but they were from institutions outside of Europe, we assumed levels of knowledge that people didn't have, which made it quite unpleasant for them because they're constantly trying to catch up. So I think to have put in a better support package for people from low-income countries would be something I'd do next time.
But the methods of online learning, did they go down well, or were they very different to the people accessing that particular package?
So we were aware of fluctuations in Wi-Fi, power, the general things that you do get in low-income countries. We supplied laptops.
Okay.
But a lot is done on phones. So I think I would have a look at courses where a lot of it can be done by phone.
Okay.
But it was an issue. Yeah.
The stroke register follow-up rates were fantastic. I mean, around 90%. I wonder why you think they were so good.
Through phones again. So addresses are quite fluid in some of the population, but everyone seems to use mobile phones, so we captured that via mobile phone. And also we employed people who understood where these sort of fluctuations in addresses, and so we're able to trace people through word of mouth as well.
And how did you manage that employment at a distance? I mean, were you reliant on local stakeholders to support the recruitment, and how did that work?
Well, there we were lucky to have a platform on which to base it through the King Sierra Leone partnership. So that had been established and had an office and some structure, one of which was that they were able to employ people. We also work with the University of Sierra Leone, and so some of the finance, such as an additional hours for the medical staff, we could then use the University of Sierra Leone to manage that money.
Thank you, Kath. Now, of course, I know you as a eminent trialist within rehabilitation research. I just wonder what perhaps some of the motivations were for you around getting involved in this project. Just tell us a little bit about that.
Well, I've spent some time in West Africa earlier in my life, and I was quite keen to I knew something about how poor stroke care was, so I wanted to be involved in that. So the motivation really was about seeing if we could change praxis. It's not easy, it was very difficult, and I underestimated the difficulties, the challenges, and the time involved. A lot of the time we get these nominal percentages for being a chief investigator, but every minute was used for sizzle, and I should have looked at that more carefully. The other difficulty with these awards is that I find a lot of the resource goes into the actual data collection and footwork, but it leaves you without, say, a postdoctoral person to help with supervision, with writing up, that kind of thing. So I found it a very sharp pyramid compared with the UK studies I've done. So I was much more hands-on than I would be on some of the other UK studies.
Good to know, but really good to hear of a project impact around, you know, the policy attention now to stroke. That must be fantastic. You mentioned the infrastructure at King's College London. You've mentioned other partners in Sierra Leone. Are there any other building blocks that you know, looking back, think were absolutely pivotal to the success of the project?
I think the community engagement. So by chance, we managed to employ someone who did have some Sierra Leonean heritage and so could speak Creole. And that seemed a big step to be able to speak in the local language. And we uncovered a lot of things that had not been said before in English. So that helps us understand the culture more. So I think that was a big thing to actually get community engagement, and they've run with it. You know, they now run themselves, and they've got money from elsewhere and been on television. They've lobbied Parliament. They've published in newspapers. So I think that was a big thing. I have to say that some of our success does feel by chance. We had the right people in the right place, so that we were lucky.
Okay. And you mentioned COVID, and obviously COVID is meaning that we all have to cut our cloth along the way. What other sort of changes of direction do you think you had to make during the project? You know, what were they, and why did you have to change direction, if you did?
I don't think we changed direction. It just took us a lot longer to get where we wanted to get. But one of the challenges that I didn't expect was illness through the project. So 3 of our UK staff who ended up in hospital. And so we had a lot of illness that you wouldn't expect. I know people are ill in the UK on projects, but this was project-induced illness in that they'd caught this in Sierra Leone so that was a bit of a challenge and a worry. And as a chief investigator, I was extremely worried about how well people were being looked after in hospital. So there was an emotional challenge that you wouldn't face in this country. COVID meant we couldn't travel there, and I felt that was a problem with delivering training. So we had to change the training to be delivered from Ghana, in Corley Boo in Ghana. But actually, that probably was better than flying in people who were used to a universal health system. And it's given a lasting partnership.
That's an interesting phrase, people flying in from a different health system. And of course, many of us are thinking about decolonisation of our educational programmes. I just wonder, perhaps, some of the sensitivities, some of the thinking, looking back on the project, around the linkage between a high-income country and a low-middle-income country around supporting stroke. Just tell us a little bit about perhaps some of those sensitivities.
Yeah, I think understanding that you can't directly translate practice. So with the example of swallowing, you know, there's no technological, very unlikely even to maybe get an X-ray. So we only manage scans through paying for it at a private hospital. But it was slightly more than that. I think, well, I'm hoping we unpick some of this later on, but I found it, I felt sorry, I sympathised with some of the volunteers because they expected staff and patients to behave in a way that you would in the UK. So sometimes there's some, on both sides, expectations of behaviour, and that can be a barrier to actually achieving things. So people will say, oh yes, you know, there's an ambulance service, or, you know, I look back at the application and I think I put what people wanted me to hear. And similarly, I felt some of the volunteers struggled because the way they treat students here or junior staff didn't work.
But what I heard was a clear sense of legacy for the project, not just in relation to policy, but perhaps also some of the people that were involved in the project. Yeah, definitely. And a bit of that is a function of COVID. Okay. Because we would have sent people out, you know, to deliver training. We'd have done more oversight instead of just coaching online. So ownership did shift, which is a good thing. Yeah. I'm going to pull our conversation to a close and just get you to perhaps reflect back for some of our listeners what you think your top tips for people who might be wanting to increase the international scope of their research. What would your top tips be during your experience of the CISL project?
Well, I think I would say apply, go for it. Really think about partnership, not only who you need, but how those partnerships are going to work and are they equal? So I think that's really, really important. Try and secure buy-in from your institution above the normal buy-in in terms of being a chief investigator. So think about how much time you need, double it, and and make sure that your department understand that there is a cost. I would make sure you've got a good senior project manager in place, because the financial and reporting burden is really high. Go and visit early. So go and visit early. Think about losing 20–30% of your staff time through illness. So they're really about organisational things.
Kath, thank you for sharing and bringing to life a project. It's really good to hear perhaps the story behind some of the slides. Thank you for sharing your experience with everyone. Kath, I assume you would be happy for people to perhaps email you with questions, because I'm sure that people will be thinking and reflecting on the webinar today. But thank you very much for your time for the council. Much appreciated.
Yes, I would be very happy for questions, very happy to look at applications if people wanted me to as well. Thanks, Chris.